Welcome, everybody, and thank you for joining us today for the continuation of OCAL's COVID webinar series. My name is Patricia Phillips, Executive Director for the Central and Northwestern regions here at OCAL, and I'll be your moderator for today's session, COVID, a medical perspective, what we know about the long-term health effects. With more than 92 million documented infections of COVID-19 and 1.9 million deaths worldwide, the COVID-19 pandemic continues unabated. The clinical spectrum of SARS-CoV-2 viral infection ranges from an asymptomatic infection to a life-threatening and fatal disease. Current estimates are that approximately 51.5 million people globally have recovered. However, clinicians are observing patients with persistent symptoms and others who develop complications for after SARS-CoV-2 infection. Because COVID-19 is a new disease, much about it remains uncertain, and in particular, the possible long-term health consequences. So today's session will see us joined by OCAL's own Dr. Pravesh Jagnandan and Dave Wilkin, followed by Alec Farquhar for closing remarks. Dr. Jagnandan, occupational medicine physician, provides a medical overview of COVID-19 and describes the long-term health effects on physical and mental health as we know them today. Dave Wilkin will discuss the importance of recognizing COVID-19 as an occupational disease, including advice on determining work-relatedness, the value of establishing a WSIB claim, and how OCAL can assist. Alec Farquhar will provide closing remarks leading us into our next COVID-19 event on January 29th, Err on the Side of Caution. To introduce our first speaker, Dr. Pravesh Jagnandan. Dr. Jagnandan is a family and occupational health physician with an active medical practice for over 25 years. He's been a medical consultant at OCAL for more than 10 years. In addition to OCAL's regular medical activities, he's been an active member of its COVID-19 response team. His clinical practice includes the management of non-hospitalized COVID patients. He provides corporate advice on COVID and return to work. As of recent, he's the consultant physician on call to offer counseling on COVID immunization to regional immunization clinic. He's a fellow of the Canadian Board of Occupational Medicine, the American College of Occupational and Environmental Medicine, and the College of Family Physicians of Canada. Dr. Jagnandan serves as a medical consultant to various organizations. And Dr. Jagnandan served as the chair of the OMA section on occupational environmental medicine and a past executive of the Occupational Environmental Association of Canada and Canadian sector of the American College of Occupational and Environmental Medicine. Dr. Jagnandan is on the executive of the Canadian Society of Medical Evaluators. He has a special interest in research ethics and serves as the chair of research ethics for 3 regional hospitals and 1 national healthcare organization. Dr. Jagnandan has presented on occupational health and disability management topics, both at local and international conferences. He is current faculty for certification in medical legal expertise, and he has provided expert opinions at legal proceedings. So no further ado, over to you, Dr. Jagnandan.
Thank you very much, Patricia, and welcome everyone. Today's topic, post-acute COVID, long COVID. First of all, I'd like to thank Patricia, who contributed to the content of this talk. Thank you very much. You just met her. And I thank Maria Rivera for the putting together of the slides in the great fashion that you'll see. I have no conflicts of interest to declare. The learning objectives of today's talk is to cover some basic science, to understand that the COVID infection does not end on day 14, the possibility of asymptomatic undiagnosed having long-term consequences, and poor outcomes as a result of COVID involves more than those just diagnosed with COVID-19. So this is a picture of the COVID virus. What do we know about the virus? It's a coronavirus. It's a family of viruses that cause commonly respiratory and gastrointestinal illnesses, both in humans and animals. These are usually mild. At times it can be severe. We know this from the past SARS in 2002 and 2003 and MERS-CoV in 2012. And now we have COVID-19. The virus is made up of the spike proteins, a membrane, a lipid membrane, and an envelope. A cross-section of the virus shows us the envelope protein, the nuclear protein inside, and the lipid membrane. So think about it as a ball, something, the covering of the ball, something inside and spikes coming out on the outside. And this is a small section of one component where you see the spike protein lipid membrane, the RNA, which is part of the nuclear protein in the inside contents. The life cycle of the virus, if we start at the top, we see that this is a virus. It attaches to what we call the ACE2 receptors in the lung. And then it gets into the cell of the lung, it breaks up and it starts to replicate. So if we look at step number 5 is where the RNA replication occurs. So basically what it's doing, it gets into the cell and it starts to reproduce itself. And every time it reproduces itself, it's creating a new virus. Now this reproductive process, because it's a RNA virus, is prone to many mistakes. So during this replication process, we'll have many mistakes. It's copying a whole sequence of RNA, and during this copying sequence, we'll have mistakes. But at the end of the day, this RNA comes together, forms a new virus, and it's released back out into the lung. And I'll come back to the reason why I'm stressing on the mistakes that occur at this point in the replication of the virus. So what is a viral mutation? Mutation is a natural process. It occurs frequently in viruses, more common in the RNA viruses versus the DNA viruses. The COVID virus is an RNA virus, sort of a primitive virus that replicates and makes mistakes while it replicates. So roughly every 30 minutes it's replicating, and the more it replicates, the more mistakes you get. The influenza virus is an RNA virus, and we know it replicates, it mutates, it changes, and therefore every year we need a new immunization. So the mutation refers to the actual change in the sequence of the genome. So this is a genome sequence. If you look at it, it's complicated. Each number represents a different sequence, and any change in the sequence is a mutation. A variant is a different mutation that occurs in the sequence is called a variant. A genetically distinct virus lineage, one or more mutations from another strain. If you think about it, if you have A, B, C, D, E, F, and suddenly the E is replaced by a R, that would be a mutation. But if that thing carries on to propagate, then that's a variant. That's a new variant. And the term strain is when this variant is of clinical importance. And that's my simple way of understanding it. Clinical importance means that it transmits differently or the disease pattern is different. So they define it as demonstrable different phenotype. They elicited different response from a human immune system, or they varied in their transmission characteristics. In terms of terminology, a mutation occurs naturally, and it always occurs every time the virus replicates. And if it persists, that's a variant. And if the variant goes on to make any clinical difference, then that's a strain. And I showed you this genetic sequence, something out of the European Center of Disease Control, because in the UK, they have this new strain, and that's called the B117 lineage. In South Africa, they have a reported strain, a different strain that's sort of similar to the UK, but independent of it. And as of recent, they have a strain in Brazil. The European CDC states that this is an expected occurrence. In and all by itself, it's not of concern. Most emerging mutations will not have a significant impact on the spread of the virus. Some mutations or combination of mutations may provide the virus with a selective advantage, such as increased transmissibility or the ability to evade the host immune response. And we know both from the UK and the South African, they are far more easily transmittable than the current strain that we have, that they had or we currently have in Canada. Just some technical stuff. We won't go through all of this. This is on the mutation itself. The mutations were found in the spike and the receptor bounding protein on the membrane and inside. So the UK variant had 17 mutations at the same time. So through replication, they came up with 17 mutations, 8 of which are on the surface of the virus. So when you have the mutation and you get a new variant, it's a process of natural selection. So the one that's most advantageous to survive will survive. The ones that are ineffective will basically die off and be killed by the body. So the ones that survive are basically the stronger versions that generally survive. This is some technical stuff on the South African variant. Also multiple mutations in the spike protein. identified in October of 2020 and now has spread to other parts of Africa and other parts of Europe. So although it has not affected disease severity, it has been found to be significantly more transmissible. Once again, just a pictograph of the genetic sequencing. And this I just put in yesterday because I mean, it's a hot topic in Ontario at the moment, COVID immunization. And I also just threw in the difference between mutation variants and strains. The first picture shows the mRNA. That's the vaccine we are receiving now, made by Pfizer and Moderna. This is the RNA virus. It's the first time this is being used. So basically what they do, they take a piece of the RNA, a tiny piece, they inject it. It stimulates an immune response, and that's how your body builds up the immune system. That's a technology that's being used currently. In other parts of the world, they have a vector virus. What this does, it uses another virus as a base to introduce a part of the original RNA into the body. So yeah, they use the adenovirus, which is a common cold virus, and they attach cells to it and they inject that into the body to stimulate the immune response. Protein subunit vaccine is they take a specific unit of the entire virus, and this pictograph shows you the spike. So they just literally cut out a piece of that and inject it into your body to stimulate the immune system. And the whole kill vaccines cultivate, millions of these viruses and then kill them and then inject it into your body. So these are all different technologies. Suffice to say, the mRNA is the newest kid on the block, and it's new, but the technology itself has been used for other medical purposes, but first time in immunization. So switching over, what is COVID-19? COVID-19 is a disease caused by the coronavirus. 11/2020, WHO declared it as a pandemic, meaning widespread human-to-human transmission and large number of countries affected. I think the slide is true as of December 30th, 2020, and Patricia gave us the numbers, which are significantly more than this in the last 2 weeks. Pictures of the virus. If we risk classify, we all know this, the elderly, the people with comorbid medical issues, diabetes, asthma, etc., are more at risk. The low risk are the under 20s. And that's where we've seen lots of our increased numbers nowadays. Symptoms we kind of heard a lot of. This is definitely not a complete list of symptoms, but generally the cardinal symptoms: fever, cough, shortness of breath, aches, pains, sore throat. Unusual is diarrhea, vomiting. Loss of smell is cardinal, one of the main things. If you have it, it's not as common, but if you have it, you just definitely need to exclude COVID. This is definitely not a comprehensive list. When someone gets infected, either they know it or they don't know it. Because as we know, the symptoms can be asymptomatic, it can be mild, it can be severe, it can be progressive. If we have to look at those that do not know that they were infected, they may be asymptomatic and they may be well, just like every other day. They may have a minor symptom that they ignored or they misattributed. I got up this morning, I had a little bit of a stuffy nose and a headache, and I attributed it to my walk in the cold last night. If you're asymptomatic, you can diagnose it with blood serology. So blood tests are available in Ontario at the moment. Most times it's not covered by OIP. It costs about $70 to $80. The long-term effects in this group are not clearly understood at this moment. Some facts on asymptomatic infections. We know it's well documented. The portion of infections that are asymptomatic have not been systematically and prospectively studied. Literature review has estimated it as high as 30 to 40% based on 3 large cohorts. Definition of asymptomatic in these studies varied depending on what symptoms were assessed and which time period. For example, they may have only asked about symptoms, headache, cough, fever, loss of smell, shortness of breath. They may not have asked about abdominal pain and diarrhea. So we're not sure exactly what was covered, and the symptoms across these studies were not the same. These studies were carried out on cruise ships, nursing homes, and aircraft carriers. And the following paragraph covers some important information, which I think we all need to be aware of. Although people are asymptomatic, they can have objective clinical abnormalities. And they provide some examples here. 24 patients with asymptomatic infection who underwent chest CT scan and showed that 50% had typical ground glass opacities, opaque shadowing. Another 20% had atypical imaging abnormalities. Some people were pre-symptomatic and developed symptoms after that with fever. Yes, although you're asymptomatic, you can go on to find changes. You may relate it to the disease. You may get better. You may not relate it to the disease. Your disease may be progressive. There's a couple of studies that just cover the asymptomatic individuals. I mean, the first one in China, quite large, 56,000, and showed a rate of 1.6%. On the Diamond Princess, a cruise ship, rate of 51%. Wuhan, China, 1,390 subjects with a rate of 15%. So you can see it kind of varies across the board, and we need to come to some consensus on the definition of asymptomatic and numbers. This is a set of cells. The cells are dying, and that's a coronavirus, all the red dots on those cells that are deceased. Just to cover testing briefly, the nasopharyngeal swab, the reverse transcriptase PCR test is what we use in Ontario, kind of our gold standard at the moment. Fairly sensitive. Serology antibody testing, I discussed that briefly. It's a blood test. It tells you that you had a past infection. What we don't know is how long those antibodies do last for. So, I can't tell you whether your infection was, 3 months ago or 6 months ago or 3 weeks ago. And I'm not sure whether that, if I test you 1 year after the infection, whether you will still have those antibodies. We just don't have that information. Antigen testing tests for the virus itself, and that's usually common with real-time point of care testing. And each one of these has its pros and cons, and sensitivity and specificity differs, but that's for another talk. Basically, I covered some of this. If you want to find out if you had COVID before, it's an antibody test. If you know you have an infection, or you were diagnosed with an infection, or infection could be mild, moderate, or severe. Most of these infections are mild to moderate, and they generally resolve. And if it's severe, you may end up in hospital, and from there, you may end up in ICU. The stats say about 80% of people will recover from the disease, 15% become seriously ill and require in-hospital treatment or oxygen. If you're lucky enough to be in the first world, if you in one of the third world countries, you're going to be, scrambling around to buy your home oxygen on the black market. About 5% become critically ill and need intensive care. It's a classification of the asymptomatic, mild, moderate, severe, and critical. So this is your lungs with the CT scan on one side and a diagram of the air sac on the right. And think about it as a balloon, an empty balloon. And air exchange occurs across this balloon. So this balloon is supplied by your blood vessels and your pneumocytes that help to keep the shape. That's your surfactant and secretions that help in the gas exchange. So when you have a pneumonia, it starts to fill with fluid. Of your balloon, if you put in some water there, the surface area for gas exchange is less because a quarter of the balloon now has water. So that's your pneumonia. Part of it is becoming filled with fluid, and that's your inflammatory process. That's shown in the picture on the right. As this evolves and gets severe, think about the balloon that fills up almost totally with water. So if the balloon is full of water, there's really very little place for gas exchange to occur. So there's little space for the oxygen to enter your blood or the CO2 to leave because your lungs is just getting full of fluid in these air spaces where gas exchange is supposed to occur. So when you start to go down this path, your body looks at this and says, wow, I'm losing this battle, but so let me, throw out all my soldiers there and let me give it the best response I can get. And this is where we get the cytokine storm. So basically your body gives out a full inflammatory reaction. The cytokines attract more immune cells to fight off the bad guys, the viruses. And everything after that is literally what I would explain as collateral damage. These things are fighting with each other, and all the other systemic effects we see are collateral damage from this major fight that's happening in your body. This fight, you can get local damage to the lungs itself. You can get blood clots that interrupt the blood supply locally to the heart, to the brain, to the liver, to the kidney. Therefore, we use blood thinners in these patients when they reach this stage. The virus itself can spread. The clots can spread to other parts of the body. The inflammatory cells itself, because it's such a significant response, can also spread to other parts of the body. And when we look at this, we find that the effects of the cytokine storm can, literally spread from the head to the toe, right from seizures, delirium, confusion, hypotension, tachycardia, cardiomyopathy, kidney failure, liver failure, rashes, vomiting, bleeding disorders, and the list is there. Suffice to say, this is ICU treatment on the ventilator, and we just have our fingers crossed that we find some adequate treatment going forward. This is just explaining the whole process more finally, and I would like you all just to watch this. It's just a 2-minute video.
We're all members of a club no one wanted to join. Different backgrounds, ages, experiences. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. These are some common symptoms, but there are many more. Some of us have been ill throughout, with others having relapses. We're still very ill. We're feeling pressure to return to work, to care for families, and get back to normal, when we still feel anything but. No one seems to be able to answer our questions or give reassurance. Will we ever get better? Will there be long-term repercussions for our physical and mental health? Is this post-viral fatigue, or are we still infectious? Will I be able to do the things that make me happy again? Can we hug our loved ones, or will we make them sick? Is this damage irreversible? Am I going to die? We just don't know, so we're sending out an SOS. Each of us has our own journey, but lots of us are feeling abandoned, dismissed, brushed off, ignored, and given conflicting advice. It can be hard for those around us to understand how ill we are. It's confusing and scary. Our numbers are growing and we need to be taken seriously. We need rehab, research, and recognition. We need to be believed, helped, treated with compassion, and supported by those around us. Please hear our SOS.
A 2-minute video probably told you everything that I need to tell you about the state of what we know now, and the state of how people are suffering, and the numerous questions that need to be answered. But the message is clear that people need to be believed, and they need help, and everyone's looking for answers. We just don't know the answers, but in the process of looking for answers, we need to be inclusive and have a whole patient approach. So at this stage, there are a few peer-reviewed studies examining the occurrence or prevalence of long-term sequelae associated with COVID. The definition is not standardized. Post-acute COVID-19 as extending beyond 3 weeks, because it's supposed to be 14 days. So post-acute after 3 weeks, chronic after 12 weeks. Lots of people have not been tested. It's been suggested that a positive test for COVID-19 is not a prerequisite for the diagnosis. This is from a publication in the UK of recent, and they use this definition for long COVID. Signs and symptoms that develop during or following an infection consistent with COVID-19, which continues for more than 4 weeks and are not explained by an alternative diagnosis. There's no alternative diagnosis to explain the symptoms, and the infection is consistent with, meaning that you don't need a positive COVID test. But the authors in this publication argued that the definition should state signs and symptoms that continue for more than 4 weeks and can be attributed to COVID-19 infection. This definition would include all the post-acute medical complications of COVID-19 under one unified definition, rather than making long COVID a vague diagnosis of exclusion. So if you can attribute it to the COVID-19 infection, it should be included here. An example would be a patient with stable high blood pressure and diabetes. It's been stable all along, that gets COVID, and 4 weeks later has a myocardial infarct. First definition will say there's an alternative diagnosis, so it's not post-COVID. The second definition will say, if it were not for the COVID, if it were not for the physical stress, or if it were not for the emotional stress, or if it were not for whatever unknown reason, we are attributing his myocardial infarct to COVID. I think there's a subtle difference here, and I think in terms of workers' health and workers' compensation, this terminology plays an important part. And these authors recommended that post-COVID syndrome from 12 weeks after infection, but there's no specific physiological changes. Preferable to use the term long COVID for symptoms of any duration beyond 4 weeks, as it's strongly advocated by the people who lived experience of this condition. And that was the video that you saw. So it's possibly a multi-system disease, can occur. It can even occur after a mild illness. So you don't have to be, severely sick in hospital or in ICU. Clinical management requires that you look at the entire patient. Just don't only look at the specific disease pattern. And obviously, if you were in intensive care, you would need more intensive rehabilitation. There's various terminology: long haulers, post-COVID-19 syndrome, long COVID-19. We know that older people with many serious medical conditions are more likely to experience lingering COVID symptoms, but even young people with relatively mild illness are experiencing ongoing symptoms. Common is this condition. The numbers are varied depending on what you're reading and where it comes from. Around 10% of patients who tested positive for COVID remained unwell beyond 3 weeks. This was based on a UK COVID symptom study. A study out of the US found up to 65% that looked at patients between day 14 and 21. So, hopefully we'll standardize the definition and be able to come up with proper numbers. This is the study out of the UK. It's called the COVID symptom study. It's an app where you track your symptoms, and it's although it's based in UK, it's global, and you see the numbers there. Put it up there as of probably the 30th of December. 2.5 million people are being tracked on this app. So it's great data. Why are some people affected? We don't know why. Bottom answer: it could be virus particle, relapse, reinfection, inflammatory, other immune reactions, deconditioning, mental health issues, post-traumatic stress, long-term respiratory, musculoskeletal, neuropsychiatric sequelae have been described in other coronaviruses, SARS and MERS. It would probably be the same year. And clinically, what we see out in practice is fatigue, shortness of breath, cough, joint pain, chest pain. Kind of clinically, what I see often patients complaining of is fatigue. The strange thing about the fatigue is not constant. Some days they'll tell you I'm totally fine, and the next day I'm totally fatigued. Loss is another one. That's I've been seeing palpitations. So the long-term effects, I'll just cover some clinical effects in not a too clinical terminology. So it can affect your lungs. The type of pneumonia often associated with COVID can cause long-standing damage to the air sacs of the lungs, scarring and long-term breathing problems. It can affect your heart. It can take months for some people to recover. Imaging studies have shown long-lasting damage to the heart muscle. Even in people with mild disease, increase the risk of your underlying cardiac issues. So the pathophysiology, we know that the ACE receptor that the virus binds to in the lung is also found in cardiac muscles, in cardiac blood vessels. So physiologically, yes, it makes lots of sense. It can definitely have a direct impact on the heart itself. To date, most studies have concentrated on the acute effects of COVID. It can cause acute coronary symptoms, myocardial infarct, arrhythmia, shock, heart failure, myocarditis. There have been studies that talked about the effect on brain, seizures, and Guillain-Barré syndrome. Guillain-Barré is a result of viral infections. We also see it as a result of immunization in some people. It's temporary paralysis that can affect your breathing. The concerning part of this is that usually people do very well is that you get them on a ventilator when they stop breathing, and you maintain them on the ventilator and they recover. But if you have a whole lot of COVID patients and your ICUs are full, and we dishing out the immunization in thousands and millions, it's just scary if you get the side effect, what you're going to do about it. And there's been a study that physiologically tried to explain it to Parkinson's disease and Alzheimer's disease. We know it can form blood clots and blood vessel problems. You can get leakage from the blood vessels. These clots can, if they're large clots, they can get into the brain, causing strokes or heart and causing heart attacks. Can weaken the blood vessels. It can cause lung problems, liver problems, kidney failure. In terms of the liver and the kidney, more acute studies, you can definitely get kidney failure and liver failure. We see this in ICU patients, either due to COVID or non-COVID patients, due to the cytokine storm. Patients generally end up on dialysis. There's an article that spoke about the reproductive long-term sequelae. Little is known at the moment. A study that suggests the sperm quantity and function may be impacted. It's much more traumatic. I know that people who recovered from SARS have gone on to develop chronic fatigue syndrome. This may be true for COVID-19. Bottom line is that many long-term COVID effects are still unknown. We know from SARS and MERS is that the most common sequelae during the period 6 months post-hospital discharge, problems, indicating pulmonary fibrosis or pulmonary vascular disease, reduced exercise capacity, post-traumatic stress, depression, and anxiety. And obviously, the treatment that you have in hospital can have an effect on the outcome, whether you're mechanically ventilated or not. Confusion, agitation, altered consciousness, gait balance issues. So this is a smaller percentage of patients, but will obviously need more intense rehabilitation. This was the other big study based in the US, a telephone study that looked at the patients between day 14 to 21. And you can see that some of the persisting symptoms are similar: fatigue, cough, loss of taste or smell, headaches, body aches, diarrhea, chest pain, confusion. The interesting thing about confusion was that the symptoms were greater after the infection than when they first reported it. Kind of people probably didn't relate it initially as a symptom, but as they started to recover, they realized there were cognitive issues. We know that COVID-19 can sometimes result in prolonged illness. This is even in healthy people, and the rate varies. Among those 18 to 34 years of age, 20%, so that's 1 in 5, reported some ongoing symptoms. So we know from SARS, there was a group of people that showed persistent and significant impairment of exercise capacity at 24 months. 40% of people recovering from SARS had a chronic fatigue syndrome. Numbers are significant. I covered some of this before. In summary, COVID-19 can result in prolonged illness and persistent symptoms, even in the young and healthy. Much is still unknown. More time and research is needed. Effective public health messaging for young adults is warranted. You all know the numbers in the youngsters have increased, and that's because either they're tired, fatigued, or believe nothing's going to happen to them. And this study also monitored social media and between the period of August 27th to September 2nd. And, the main ongoing complaints were respiratory, heart, and neurological. Sort of a clinical textbook, ongoing symptoms and percentages at various times. Clinically, in practice, we've definitely seen mental health issues, fatigue, cardiac complaints, shortness of breath, some skin issues, sleep disturbances, and the dentists are reporting mental issues. Same study out of the UK group, they have a doctors group that includes doctors, nurses, and other healthcare professionals with COVID, and they just track their symptoms, ongoing symptoms, from cardiac myocarditis, arrhythmias, mast cell activation syndrome, which is types of allergies, interstitial lung disease, vascular disease, myopathies, hepatitis, pneumonia, literally head to toe. This is just a comment on mental health, because in medicine, we always look for diagnosis. So basically, the commentary says, as a result of these exceptional challenges, lives are being lost that could, in other circumstances, have been saved. And we all agree with that. Non-clinical professionals in other essential roles, such as the justice system, media workers, social workers, etc., may also feel the profound effects of being required to perform already highly challenging duties in a more constrained manner, which may lead to risk of being more difficult to manage. How such events will impact frontline key work teams remain unclear, but it is likely that many will experience a degree of moral distress and some moral injury. Moral injury is defined as a profound psychological distress which results from actions or the lack of them, which violates one's moral or ethical code. Morally injurious events can include acts of perpetration, acts of omission, or experiences of betrayal from leaders or trusted others. Unlike post-traumatic stress disorder, moral injury is not a mental illness. Although experiences of potentially morally injurious events can lead to negative thoughts about oneself or others, I'm a monster, my colleagues don't care about me, as well as a deep feeling of shame, guilt, and disgust, they in turn can contribute to the development of mental health problems, including PTSD and anxiety. I think we as a society need to reflect on this statement, kind of just talk to people and don't really, we're not supportive enough. We don't take the time to understand moral dilemmas occurring in people all the time. And this concept of moral injury, I mean, I'm not sick, but I'm totally disturbed by what's happening around me, either because I can't control it or because the people around me that are making all the decisions are making decisions that are what I perceive to be morally wrong. It's something just to reflect on. Long-term effects of being on the ventilator, and I'm just rushing a little bit. Headaches associated masks. I'll cover this last part briefly. That was the main gist of my talk. It was a clinical aspect, but the pandemic closure itself had significant effect on families, children, societies, and everyone else, right? Ranging from mental health, worsening of pre-existing conditions, and precipitating new mental health issues. The incidence of suicide has increased, substance use disorders have increased. We know that people are working in isolation, there's decreased income, financial uncertainty, health uncertainty, exposures are unknown. How do I go from work to work, public transport, private transport, and then we have the vulnerable workforce that have to get up and go to work on a daily basis. And then we have all the medical issues that were suspended, from delayed diagnosis, example, breast cancer, delayed treatment, example, surgery for the breast cancer, increased complications from delaying treatment, increased physical activity, and complications from using PPE all the time. Basically, inequalities and societal deprivation will increase. The World Economic Forum put out a publication that looked at all the effects of the lockdown. And basically, this conclusion is that the social deprivation determines health outcomes. So the social determinants of health, as we know, are significant throughout the world. Inequalities are here to stay. The COVID-19 economic crisis disproportionately affects the poor people, both locally and internationally. As one teenager put it, the life you thought was boring is the life you are hoping you get back to right now. Generations could be destroyed. The long-lasting effect on the prospect of the young generation, being undereducated, not educated, the labor market, and very quickly, 5% of adults felt adverse effect on the mental health. Just some slides, numbers demonstrating psychological issues of health, disruption in education, fought hiatus thoughts. In Ontario, publication by the government between the period of January to June 2020, looking at opioid-related deaths, and I'll summarize this. So during this period, there was a 38% increase compared to the 15 weeks prior to the pandemic, the amount of people that died from an opioid overdose. And if that number continued, and the publication is not out yet, as of end of 2020, there would be a 50% increase in the people that died from an opioid overdose. So this is just one medical condition related to substance use disorder. And if we look at all of them, the numbers are just not out there for, we are going to be in for big surprises. So what we know, public health measures on children and family indicate that school closure and stay-at-home orders negatively affect access to nutritional and vaccination programs through schools, and increase the risk of financial stresses, mental health problems, decreased movement behavior, and increased risk of factors related to child maltreatment. So the direct effect on children and families, psychological impact, the bottom half, numerous psychological effects, including PTSD, confusion, and anger. Basically, you start off at the level of the child, then the family, then the community, and the society. A whole lot of social risk factors, caregiver stress, major issue, substance use, 7.5% reported an increased use in alcohol. More people did not start using marijuana, but those that used marijuana used it more often. Stress with managing the children, managing remote learning, poor behavior by kids, relationship issues. So in summary, Ontario families are struggling, need our help. And just to finish it off, we talk about the marginalized, the poor people, and how they're going to be worse off. We can look at it locally in our Ontario's perspective, Canadian perspective. We can look at it globally. Just a point on malaria. This is a disease that has been around for forever, that I can recall. Annual death rate around over 600,000 per year. And if you look at this graph, the blue section is people under 5, children under 5 dying. You see it's ranging between 400 to 500,000 per year. So malaria kills between 400 to 500,000 per year, and probably a million before this per year. And the main people that die are young kids. And we really don't care because it's in Africa, and 95% of the cases of malaria occur there. So when we talk about, the inequalities of health, we can think locally, but we need to think globally. And this malaria is, easily treatable, preventable. 2019, there were 229 million cases of malaria. 90% of the cases are under 5 years old that die every year. All I'm saying is just let's broaden our minds, think about the people that are disadvantaged, both locally and globally, because we all need to get through this together and, be better off at the end. Thank you.
Thank you, Dr. Jagannathan. That was a fantastic presentation, a lot of great information to take in. And just to say that we will be providing the slide deck for those that were asking, and a copy of the presentation on our website. I think, Dr. Jagannathan, the medical overview of the long COVID and the video that you showed really has some really big impact. Looking in the comments, even talking about how it was a powerful message. I think people, you hear about the long COVID, but to really appreciate how many people are suffering from that, and still not even understanding what it is, and what the effects are going to be going forward. So thank you very much for your presentation. It was fantastic.